Hello and welcome to the presentation. My name is Kim Ezekwesili, and along with my colleague Casey Jafon, we will be talking about postoperative delirium in the elderly patients. The objectives, we'll talk about the introduction to the case study, delirium in the elderly, why bother, physiological factors and pharmacological factors that contribute to delirium, other factors that may also contribute to delirium, differentiate between postoperative delirium and postoperative cognitive dysfunction, follow up with a case analysis, and we'll conclude the presentation. This picture is a brief reminder of what happens with the delirious patient. We can see signs of confusion, the use of restraints, eventually patients that do try to get out of bed and put themselves at danger of injury. Our case study, we have an 81-year-old female with a past medical history of smoking, hypertension, peripheral vascular disease, stent placement in the femoral and iliac artery, and laparoscopic colon surgery under general anesthesia. Briefly looking at the medical history, we can see she has multiple comorbidities that places her at an higher ASA risk status. Her advanced age of 81 years old also places her at a high risk of delirium. Her EKG was a normal sinus reading. She did have a stress echo that was negative for ischemia, but showed some left ventricular hypertrophy and dysfunction. An ultrasound was also negative for significant stenosis. This is a good pre-op check because for patients like this, you want to have a full cardiac workup to make sure you rule out any factors that places her at a higher risk index. She did have recurrent UTI prior to admission. Her troponin was 0.04, hemoglobin was stable at 12.9, and her platelets were 260. Her electrolytes were within normal limits prior to the surgery. Her blood pressure was elevated at 168/78. Her home medications were continued until the day of surgery. This included Plavix 75 milligrams daily, simvastatin 20 milligrams daily, valsartan 160 milligrams daily, bisoprolol 10 milligrams daily, and bromazepam 6 milligrams. It is interesting that the case study didn't mention any history of anxiety, but looking at the bromazepam, we will assume that she does have some history of anxiety that will require the use of a sedative. The patient was then induced under anesthesia with propofol, atracurium, and sufentanil. The doses were not specified. Oral intubation was performed with an ET tube. General anesthesia was maintained with desflurane and a 50-50 mix of nitrous oxide and oxygen. The case took a total of 3 hours with no issues reported intra-op. She was reversed with neostigmine and atropine. Again, doses were not specified, followed by successful extubation, at which point she was transferred to the PACU and eventually to the surgical ward. Her pain was controlled with IV propacetamol, 500 milligrams, 4 times daily, nefopam, 20 milligrams, 3 times daily, and morphine PCA pump on demand, which was used for 48 hours. On post-op day 4, she developed multiple episodes of confusion, logorrhea, and disorientation. Her temperature spiked to 38.4 on post-op day 3 and normalized to 37.2 by post-op day 4. This is an early indication that there was likely an infection or septic process that was going on. Physical exam reported abdominal tenderness, diarrhea with via the pre-existing ileostomy, and otherwise normal cardiac and pulmonary auscultation. Her leukocytes were elevated at 10,000. Her electrolytes were normal, and her hemoglobin remained at the pre-op level of 12.9. A CT scan was ordered, which showed a 3 centimeter diameter fluid collection at the colorectal anastomosis. As we can see, the patient is developing early signs of delirium, an event that can occur within 2 to 3 days following surgery. It can lead to eventual admission in the ICU and mortality if left untreated within 6 months for the elderly patients. She received broad-spectrum antibiotics for the fluid collection, and she went back to the OR for an exploratory laparotomy. At this time, during surgery, peritonitis was confirmed. The surgery was concluded, but due to respiratory complications after the surgery, she required ICU support on the ventilator and sedation with propofol and midazolam. She was extubated 8 days after the second surgery, at which point she developed another episode of delirium, which happened 1 day after the extubation, so this will be on post-op day 9. A nicotine patch was used because she does have a history of smoking to attempt to reverse delirium with the thought that she was having some withdrawal to the nicotine in cigarettes. This was unsuccessful. However, once her oral bromazepam was resumed, which was her home medication, the episode resolved within 2 hours. She was eventually discharged and remained stable at a 1 year checkup. Postoperative delirium in the elderly, why do we bother? There's a false assumption that delirium is common in the elderly patients above 65 years old, and dementia is also present in most patients. This is a false assumption. The presence of an altered mental status that varies from baseline isn't part of the postoperative recovery process in the elderly patients. Combining this with other comorbidities, it can lead to adverse long-term effects, and left untreated, it can lead to the postoperative cognitive dysfunction, which lasts longer than the postoperative delirium itself. The reported incidence of postoperative delirium varies widely. In the general population, in all age groups, it ranges from 5 to 10% for general surgery. However, for the elderly, there's an increased rate of this. In general surgery for the elderly patients, postoperative delirium ranges from 10 to 15%. For orthopedic surgery, it ranges from 28 to 61%. And for cataract surgery, it ranges from 1 to 3%. From this, we can see that general surgery and orthopedic surgery, which are more invasive than the cataract surgery, places the patient at risk of postoperative delirium, and the range is higher than what's expected in the average age group in the general population. The confusion assessment method, CAM, is used as a simple tool at the bedside to assess the patient. It involves 4 features. Number 1, you ask the patient about any acute change in mental status that is fluctuating. The bedside nurse is looking for evidence of acute changes in mental status from the baseline of the patient. Has it fluctuated in the past day with increasing or decreasing severity? Number 2, inattention. We're looking for difficulty in focusing and an easily distractible patient. Number 3, disorganized thinking. The bedside nurse is looking for disorganized thinking, incoherent, unclear, and illogical flows of idea. And number 4, altered level of consciousness. The bedside nurse will rate the patient's level of consciousness. Is the patient alert, hyper-alert, lethargic, stuporous, or comatose? The bedside nurse or the patient's family member, if present, can help assess and answer the questions. The presence of number 1 and number 2, along with either number 3 or 4, indicates that delirium is beginning to occur in the patient after surgery. On this slide, we'll look at the different physiological factors that contribute to delirium. Age. Studies suggest that an advanced age greater than 65 or 70 can lead to postoperative delirium. This is likely due to the changes in the number of neuronal cells and the delayed transmission of synapses that occur as people age. Combining that with coexisting diseases like dementia, stroke, hydrocephalus, depression, heart disease, and other comorbidities, the patient is at increased risk of postoperative delirium. The American Society of Anesthesiologists suggests that an ASA status of 3 and above places the patient at increased risk of postoperative delirium, which is more increased when you combine that with the advanced age greater than 65. The male gender is also assumed to have an increased risk of delirium, although there's no exact pathophysiologist that can explain why. Studies suggest that men are less likely to take care of themselves compared to women. Women are more likely to visit the hospital and follow up with a primary care provider and take medications as prescribed compared to men. Dehydration or malnutrition can also play a role. Malnutrition occurs as the elderly patient has poor appetite and may eat less than normal. This can lead to protein imbalances that affects the binding of drugs that are given during anesthesia. Most patients are required to be NPO for more than 8 hours prior to surgery. Dehydration can occur and also cause electrolyte imbalances. Looking at the metabolic imbalances, as we've discussed, the electrolyte imbalances can occur like hyponatremia, hypocalcemia. Combining it with surgeries like GI and GU surgeries that uses irrigation during the procedure, hyponatremia can occur and leads to confusion and possibly seizures in the elderly patient. UTI has also been shown to place the patient at the increased risk of postoperative delirium. Urinary tract infections are common in the elderly patient due to the changes that occur to the urinary tract itself. Sensory loss, like hearing and vision loss, are another part of the process that occurs with aging. After surgery, if the patient is unable to return back to normal, which means if they're unable to get their eyeglasses or their hearing aids, it can cause an acute sensory impairment that can lead to delirium itself. Finally, sleep disturbances can also lead to postoperative delirium. Combining insomnia and other factors like lack of sleep can also lead to this. Looking at the pharmacological factors, it is important to say that prevention is key. The goal is to decrease the Beer criteria drugs, anticholinergics, and the use of benzodiazepines during the pre-op and intra-op period, as well as the post-operative period. Nagelhout, this table does show suggestions of the use of drugs for the perioperative period and the anesthesia considerations that occur with these drugs. Multiple drug-to-drug interactions can occur, especially during the intra-op period, combining it with drugs that may be taken at home prior to the surgery. High alcohol intake or abuse and withdrawal from chronic alcohol or benzodiazepine use can also lead to postoperative delirium, especially when the patient isn't given any of these drugs during the intra-op period. The use of regional anesthesia for post-op pain control can help reduce the amount of opioids that are used in the post-op period and reduce the risk of postoperative delirium. The duration of anesthesia can also increase the risk of postoperative delirium. Surgeries that last 2, 3, or more hours in patients that are elderly will also lead to increased dosages of drugs that are used in the intra-op period, and these drugs can also continue to the postoperative period and lead to postoperative delirium.
Additional factors that may contribute to delirium, which we will discuss further in the next few slides, include type of surgery performed, an increased length of hospital stay, the use of restraints, frequency of orientation or reorientation, the use of patient glasses and hearing aids, the post-operative environment, family or a familiar presence, and current hospitalization prior to surgery. Post-operative delirium, or POD, and post-operative cognitive dysfunction, or POCD, are the most frequently occurring neurologic phenomena in older adults. POD and POCD are distinct conditions, with age over 65 years being the predominant risk factor for both. So how do we then differentiate between post-operative delirium and post-operative cognitive dysfunction? We'll begin with post-operative delirium. POD is characterized by disruption of perception, thinking, memory, psychomotor behavior, sleep-wake cycle, consciousness, and attention. Its clinical presentation varies with hypoactive symptoms such as decreased motor activity and depression, as well as hyperactive symptoms such as aggression and agitation, and in some cases even a combination of both hypoactive and hyperactive symptoms. In some cases, the hypoactive symptoms are unrecognizable, which results in misdiagnosis of POD. Symptoms typically manifest acutely within the first few days after surgery and can last for several days or weeks. The exact cause of POD is not known, but is likely multifactorial. Risk factors that have been associated with the development of POD are older age, male gender, dementia, history of alcohol abuse, depression, duration of anesthesia, poor functional status, abnormal electrolytes and glucose, Parkinson's disease, cardiovascular disease, dehydration, metabolic diseases such as diabetes and hyperthyroidism, anticholinergic drugs used intraoperatively, patients requiring admission to the ICU, inadequate pain control, an ASA greater than or equal to 3, low serum albumin, and the type of surgery. Now, surgeries with a higher incidence of POD are occurring in aortic and orthopedic surgeries, such as femoral fractures. POD is associated with an increased risk of postoperative adverse reactions, such as pulmonary and cardiac reactions, increased length of hospital stay, increased healthcare cost, poor functional and cognitive recovery, and unfortunately, even death. So, postoperative cognitive dysfunction is often reported as being part of the same continuum as postoperative delirium. And even though they're both neurocognitive disorders that contribute to increased hospital costs, morbidity, and mortality, there are differences. So, POCD is characterized by an array of cognitive impairments such as memory deficits, difficulty with concentration, impaired comprehension, and delayed psychomotor speed. But unlike postoperative delirium, the onset of postoperative cognitive dysfunction is subtle, and neurocognitive deficits may not present themselves until weeks to months after surgery. And this ultimately results in the inability to work, a decline in activities of daily living, and perhaps a need for assistance and care. Currently, there are no universally accepted diagnostic criteria for postoperative cognitive dysfunction, neither is there a standard definition. So, to diagnose postoperative cognitive dysfunction, a battery of time-consuming and sophisticated neurocognitive tests must be done preoperatively and postoperatively to identify this cognitive decline after surgery and anesthesia. So, establishing a baseline cognitive function is critical because preoperative cognitive impairment may be present prior to the surgery. However, preoperative test timing, specific tests, and test interpretations remain inconsistent and often debatable. Some risk factors for postoperative cognitive dysfunction are also controversial, with advanced age being the most agreed upon. Other risks may include a lower educational level, longer duration of anesthesia, preoperative depression, preoperative cognitive decline, postoperative infection, and a second operation. The cause of neurocognitive postoperative complication is still unknown, but like postoperative delirium, also appears to be multifactorial. However, there are several theories that have been postulated. These common theories include cerebral hypoperfusion, including severe hypotension and embolic events, the inflammatory process associated with surgery, and general anesthetics. And similar to POD, the physiologic mechanisms responsible for POCD are yet to be elucidated. However, the potential mechanisms include neuroinflammation, dopamine excess, acetylcholine deficiency, and central cholinergic deficiency. An array of human biomarkers reflective of these mechanisms are now being investigated. However, currently the diagnosis of POD or POCD is not supported by any specific biomarkers. Now that we have discussed factors that may contribute to postoperative delirium in the geriatric population, let's consider the case study once more. Anesthesia considerations. As Ike previously presented, standard anesthesia drugs were used for induction, and although those doses were not specified, the stated drugs appear to be short-acting and were thought to not have played a major role. The length of the surgery was stated to be about 3 hours, which, as we discussed in the previous slide, may have played a role in the patient's delirium, as longer surgeries necessitate anesthetic drugs for longer durations of time. Postoperative medications. The use of morphine in the PACU may have elicited CNS depression, causing a depression in respiratory rate, but not necessarily delirium. The length of stay in the PACU was also not noted, but the patient was admitted to the hospital, and as we have discussed, an increase in the length of hospital stay can absolutely result in unfamiliarity and the onset of delirium. Peritonitis. The authors of the case study identified peritonitis as the probable cause of the incident. Elderly patients may have a delayed or blunted response, such as fever, to infection. Thus, peritonitis may have already developed immediately after surgery, and the effect, as a result, was noticed days after surgery. Drug interaction and withdrawal. The combination of opioids and benzodiazepines used to maintain mechanical ventilation in the ICU for 8 days after the exploratory laparotomy may have contributed to the patient developing a dependence. Upon extubation, all sedatives were discontinued, although the patient's previously prescribed home medication of the benzodiazepine bromazepam was not readministered. This is supported by her return to stable neurological condition 2 hours after her home medication of bromazepam was resumed. Overall, there is no consensus in the literature regarding the most appropriate anesthetic technique for the elderly surgical patient. But it is so very important that we as healthcare providers know our patients, as the treatment of postoperative delirium begins with prevention. Preoperatively, healthcare providers should identify patients who are at high risk for postoperative delirium, and as we have discussed, this includes patients over the age of 65, those patients with chronic cognitive decline or dementia, patients with poor hearing or vision, the presence of infection, current hip fracture, or severe illness. In combination with the risk factors, the physiologic stress of surgery, which is determined by the extent of the operation, may cumulatively contribute to the development of postoperative delirium. Other recommendations for anesthesia providers include administering regional anesthesia for postoperative pain control in hopes of potentially preventing delirium, as well as conducting a thorough review of medications preoperatively while avoiding medications per Beer's criteria. Once postoperative delirium is diagnosed, treatment is dependent upon the identifying cause. After treating the underlying cause, it is recommended that healthcare providers, as this is absolutely a multidisciplinary effort, use multi-component non-pharmacologic interventions such as frequent reorientation, a calm environment, eliminating restraint use, and ensuring the use of hearing aids and glasses. The use of pharmacological interventions such as haloperidol or lorazepam should be reserved only for those who are highly agitated and are threatening harm to themselves or others. Presently, there's no cure for postoperative cognitive dysfunction, and patients who suffer from it may or may not recover to their preoperative cognitive state. Again, this is why we stress that we want to prevent this as much as possible. So because postoperative cognitive dysfunction pathogenesis is multifactorial and unclear, strategies should be aimed at prevention. Unfortunately, there are no proven effective strategies. However, based on the knowledge that the elderly have decreased nervous system function and decreased cognitive reserve, effort should consist in identifying the risk factors that we've talked about and tailoring anesthetic management to minimize them. Recommendations are aimed at maintaining oxygenization and cerebral perfusion. Because it's speculated that postoperative cognitive dysfunction may be caused by general anesthesia or surgery, it's only prudent that surgeries should be as short or as minimally invasive as possible. And lastly, involving family in the patient's care can be tremendously preventative, as familiar, effective communication between the patient and their family can aid in the reduction of delirium. Here's a list of our references. Ike and I thank you for listening to our presentation, and we hope you found it helpful in learning more about postoperative delirium in the geriatric population.